get started. I'm going to introduce Dr. Michael Fischbach, who is Professor of Clinical Immunology in the Department of Medicine, and he's going to talk about rheumatoid arthritis, and I think you'll find this very interesting. Thank you.
Thank you. Well, you're all looking for the handouts, so don't look very hard because you're not going to find them. And the reason you're not going to find them is because this is the way life is. And one of our faculty, his father died, and so I'm taking over the service, and since I was on the service, anyway, that's the way life is. So I've decided to change the topic because I thought rheumatoid arthritis was too restrictive. And can you hear me? This thing isn't on. I don't.
Yes, we can hear you very well. There's just no feedback.
All right,
so it's
that's
weird.
excellent.
Yeah.
So I thought it was too boring and too specific. So I decided we would branch out a little bit. Now I don't know what the background is of everybody. So can you sort of yell out like what you do, just of some people?
Dental hygiene. Dental hygiene. There's a couple of nurses, a couple of social work.
Okay. Well, we're going to have to go really slow then because, and I don't mean it in any way. I mean, if you did dental hygiene talk, I'd go, huh? So if you don't understand anything, you know, throw a napkin at me or something soft and we'll go back over it, all right? I want to kind of give you an overview of some of the things that you have to think about in elderly people, all right? And so there are really 5 major types of diseases that we're going to talk about. One is osteoarthritis, which is the most common kind of arthritis. Rheumatoid arthritis, there's a kind of crystal that's deposited in the joints called calcium pyrophosphate deposition disease, or the common name for it is pseudo gout because it's like gout, but it's not. The last two go together, PolyMyalgia, Rheumatica, and giant cell arteritis. And these are things that are seen in elderly people. They're also seen in everyone else. So we'll start with osteoarthritis. This is the most common type of arthritis. 16 million people affected in the United States. This is what your grandmother has, okay? It's non-inflammatory, which means if you look, it's not red hot and swollen. And it's due to the disintegration of cartilage. And this is quite different from the other things we're going to be talking about. So for example, here's a biopsy of some cartilage. And this is normal cartilage. You can see it's very pink. And here's the osteoarthritis cartilage. And the pink are proteoglycans. And so these chondrocytes, these cartilage cells, are not feeling well. And so they're not making as much glycoprotein as they should, proteoglycans as they should. And there are lots of them. So it looks like they've proliferated, hoping that if they have more of them, they'll be able to make it, but they can't. So that's one of the problems. And what happens if that happens? That means you make very bad cartilage. So cartilage should be smooth, and here you can see this is all frayed at the end. And this is when the orthopedic surgeons say they're going to do a scope and they're going to clean it up. This is what they're cleaning up. Besides getting this friability of the cartilage, you can also get big tears in the cartilage. And here's looking through an arthroscope. Arthroscope, can you see this very well, or should the lights go down? Fine. Now here's normal. You see how smooth the cartilage is. And here's looking through a knee of a patient who has osteoarthritis. See how it has all of this teared and ragged cartilage? And depending on who the orthopedic surgeon is, if the guy needs some money, he's going to say, I'm going to clean this off for you. And you're going to feel so much better. And if he doesn't, he's going to say, there's nothing I can do about this. So it really depends. It's very controversial whether these should be fixed or not. All right, we asked for a volunteer one day, and we had this nice older woman who volunteered to let us cut her finger off, and we did this so we could make this slide. And then it ended up in some chili, right, that you all know. So this is a autopsy specimen of a finger that had osteoarthritis. And so here's the bone. Is this all clear what we're looking at to everybody? Yeah. Okay. So here's the bone, here's the cartilage. Here's the synovium. Now the synovium is what we're going to be talking about in rheumatoid arthritis, but it's normal in this. And you can see the cartilage is missing. Here's that place where I said you can see the tear in the cartilage. Here's the friability on the top. And here's a big piece of cartilage that's missing. Here's a piece of cartilage that's missing. So this would actually be bone on bone, which would be very, very painful. And then here's the big osteophyte. And when you go in the grocery store, rather than reading the magazines, which I find sort of stupid, if you stand there and look at people's hands, it's really interesting. And then you come up and say, may I feel your fingers? and they smack you and stuff. But if you were to look, you'd see there'd be bony excrescences on the first joint, which is the distal interphalangeal joint, and the middle one, which is the proximal interphalangeal joint. And these are the bony things. These are called Heberden's nodes up here and Bouchard's nodes here. And these are those things that you see on your grandmother or your aunt, older aunt or somebody, that makes you think the patient has arthritis. And in rheumatoid arthritis, these would be soft and tender, and in osteoarthritis, they're a little bit tender, but they're very hard, and they're bony, as you can see, it's bone. And here's a patient who wore out their knee. Now this is looking at the knee with it open. So here's one of the, you don't care. The thing I want you to look at is here's the cartilage. And here you can see it's just gone. There's a hole here. That's called an osteochondral defect. And there are some people who think that can be fixed. There are some orthopedic surgeons who will take a piece of cartilage here or maybe from another knee, and they'll put a plug in there. But what usually happens is the thing falls out and it doesn't work. And you have two operations, and you're just the way you were, and you're very grateful to the surgeon for doing this to you. You say thanks a lot. There is a guy in town who will take the cartilage. Nobody does this anywhere except in Boston. They take a piece of cartilage, and then they make a single cell suspension. They send it to Boston, where the thing is grown and enlarged, and they send it back, and they inject the cells, and they think it'll fill in here. And I guess it does if you're a spur or somebody, but if you're a normal elderly person, it doesn't work very well. So most people don't do this. And you can see what happened to this person. They ended up having to have a total knee replacement. And that's why we have this knee to look at. All right, what are the risk factors for OA? Older age. If I think I have the data here, literally nobody in this room would have osteoarthritis except me. And I don't, but I could. Because older age is really important. You have to be, it's associated with people who are overweight. But interesting, it's only overweight women. Overweight men don't seem to get this as bad, and I don't know why that is. Trauma is associated with this. They've done some nice studies. If you graduate from Johns Hopkins Medical School, you have to sign up for the rest of your life to let them study you. And so they've looked at people who graduated from medical school in the 1940s. And if they had a simple injury, like what does Hopkins do? Lacrosse. So they had a lacrosse injury to their knee. And now as they got older, it turns out where that injury was nothing, and they sort of, maybe they limped for a couple days, that turned into osteoarthritis. Repetitive joint damage. We see that a lot at the VA, people who were paratroopers in this, in the Korean War, mainly now we're seeing, or in Vietnam, that they have, from repetitive jumping out of planes, they end up with things. And then there are genetic factors that have to do with an abnormality of one of the collagen genes. These are very rare, and I don't think we've ever seen a case of that. So look at this. Middle age and older. 1% of patients have osteoarthritis under the age of 30. 10% of patients, people 30 to 50. 60% of all the OA patients are in this age group, and if you're 70, you're for sure going to have it. So that's why if you hold people's hands, or the elderly people in the grocery store, you can make sure that you're diagnosing it. The systemic manifestations are none. Okay, it's not a systemic disease, it's only in the joints. The presenting symptoms, the patients present with polyarthralgias that have been present for several months. People put up with this for a long time before they seek medical care. I don't think we need to go over this. So part of the things, if you're doing a physical exam on people when they're coming in, they'll have asymmetrical joint involvement. So that means they'll have it on one side and not the other. And it tends to be the larger joints. They may have normal range of motion, but it'll be painful. Again, there'll be no swelling, no inflammation. Hard bony enlargements are called osteophytes. And then in the hands, these carry special names. In other places, they're just called osteophytes. The common joints are the cervical spine. So these are people who have bad necks. And this has something, a lot of problems in the dental chair. When your neck is put back for an extended period of time, if you have osteoarthritis of the neck, it can be very, very painful afterwards. The lumbosacral joints, low back, hips, knees, ankles, and the labs are all normal. And I said not the MCPs, which are these joints right here, these knuckles. They are never involved in osteoarthritis. If those are involved, then you're going to think of something else. And here's an example of the swelling. Can you see the swelling? Right there. Right there. see the angulation. It looks much worse on the real one. I don't know why. Here's the spine. And you can see all these things sticking out here that you shouldn't have. So that's osteoarthritis of the spine. So what is the assessment? So the patients come to you complaining of pain. That's all they ever have. They don't complain of anything else usually. Sometimes the physical functioning of their hands aren't very good if they're a little bit distorted. We worry about how do they function in life, what is the quality of their life, can they do performance-based tasks. These are all the things we worry about. In, for example, elderly people, if they had osteoarthritis, the hip would have instability in their hips. And then if they can't have a wide-based stance or their stances and they start to fall, we would all step over like this to grab ourselves, and they can't do it because the arthritis prevents them from moving as well. So the question is, why do you have pain? Well, there are pain fibers in the membrane, the joint capsule, the ligaments, muscle spasm. These are the things that cause the pain. And so if you're going to alleviate pain, you'd want to do something about just giving pain medicine. So the suggested main treatment is Tylenol. And you can use up to 3 grams a day without having problems with the liver. Then if Tylenol doesn't work, then they recommend you use non-steroidal anti-inflammatory drugs. And this used to be quite an interesting topic, but now it's not, because now we use all the drugs from the 1960s, right? Celebrex and Vioxx and all of the COX-2 inhibitors are all now gone. So we're back to the really old-fashioned drugs. So patients who come in on non-steroidal inflammatory drugs with osteoarthritis should be on something to protect their stomach so they don't get a perforation, ulcer, or bleed. Physical therapy can really help patients, particularly heat and cold. And the best thing that ever happened to help these patients is joint replacement surgery. That really has done more than anything that a rheumatologist can do. All right, rheumatoid arthritis. We're going to talk a bit about it in general, but we're going to mainly talk about elderly versus the younger patient. So in the elderly patient, males equal females, whereas in patients up to the age of 60, females predominant over males. It's 3 to 1 females to male in normal people, in younger people. The onset in elderly people is acute. It's very, very severe, and they come in all of a sudden complaining of pain, whereas in people of a younger age, it's very insidious, and they just have a little bit of pain, and it gets a little bit worse, and they can't tell you when it started. But elderly patients usually can. The large joints are involved more often, so it's more often the knees and the hips and the ankles. Whereas in the average person, it's the small joints of the hands and feet that are involved. There's more weight loss, fatigue, and greater disease activity in elderly patients than in younger patients. And it probably has a worse outcome, although this has not been studied well, secondary to all the comorbidities that go along with elderly people, for example, diabetes, hypertension, etc. And some people think there's a poor ability to repair the damage as you get older. These things are not well documented. So rheumatoid arthritis was not a disease of antiquity. Rheumatoid arthritis was first described in the 18th century, whereas all the other kinds of arthritis they found in the pyramids. So here's a picture by a person named Caro, and if you look at the hands, you can see that hand doesn't look right. And if you get a close-up, which I don't know, this isn't, you're going to think I'm crazy making this up. See how nice these fingers look and see how swollen this is? Well, anyway, in the real one, it's swollen, and people say, well, that's artistic license, and it probably isn't. The patient probably really had rheumatoid arthritis. And this is said to be one of the first documented evidences of rheumatoid arthritis. All right, the other thing that's interesting about rheumatoid arthritis has nothing to do with elderly people. I just think this is fascinating. This is a map of the eastern United States. Does it project very well? Okay. And where all these circles are archaeological digs. And where the dark circles are where they found bones. So it was in Kentucky and part of Tennessee. And what they found was mummies that had erosions in the bones that looked like rheumatoid arthritis. So rheumatoid arthritis was first described in the New World. It's one of the few diseases that went from North America to Europe. Everything else came the other way. So here are some of the bones, and you can see some of these bones have these holes in it that look just like patients with rheumatoid arthritis would have. So anyway, this is the first archaeological evidence of rheumatoid arthritis, and it takes place in the United States. Here's just more of them. So rheumatoid arthritis, as I've said, is the only disease we know of that went from the New World to the Old World. All the other diseases went the other direction. So why did that happen? I don't know. Now, it used to be said that rheumatoid arthritis was just arthritis. For God's sake, stop complaining. You just have arthritis. That's what the children said to their older parent. You know, I'm tired of you whining all the time. And now some very nice studies were done, and actually these were done a number of years ago, that shows that rheumatoid arthritis in the severely affected individual has the same mortality as 3-vessel coronary artery disease or stage 4 Hodgkin's disease. So it does shorten life expectancy. Well, let's, go through all this. Here's what we'll look at. It's easier to see it here. And I won't give you all the background. So look at this. This is coronary artery disease, and this is the number of vessels. That's 1 vessel, 2 vessel, 3 vessels, okay? And left main, we won't talk about that. So here's survival, here's years. So you can see if you have 3 vessels involved, your 50% survival is only like 4 years, 5 years. If you do rheumatoid arthritis, you do a joint count, which means you count how many tender and swollen joints the patients have. You can see there are several of them. This is less than 10 joints, this is 10 to 20 joints, this is 21 to 30, and this one is greater than 30 joints. So if you have very bad rheumatoid arthritis, you can see that your 50% survival is exactly the same as it is if you have coronary artery disease. Or if you have anatomical staging of Hodgkin's disease, this is stage 1, stage 2, stage 3, and stage 4. And instead of doing joint counts, we did activities of daily living scores. We asked patients to say how they could do things, button buttons, get up out of bed, bathe themselves, etc. Those people that had the worst scores had the same survival as Hodgkin's disease. Now the patients don't die of rheumatoid arthritis, they die of all the problems, the medicines that are being given, or they trip and fall and end up with a fractured hip, etc. Now, rheumatoid arthritis is an inflammatory disease, and here's an example of a synovium of a normal patient. You can see it's 1 cell layer thick, and it's pretty fluffy in here, and there's blood vessels. Now what happens to a patient with rheumatoid arthritis? So it looks like this. It almost looks like a lymph node. It's full of lymphocytes, and instead of being 1 cell layer thick and very fluffy, it's a solid organ. And if they cut it out, and here's some they did when they did a synovectomy. I took out the synovium in the knee of a patient with rheumatoid arthritis. Look how much tissue there is. In a normal person, there's none. So something's happening that's making the cell grow. And here's a cartoon on this side, and here's the x-ray on this side. And what I'm going to show you here is we used to have these pins we wore, these big pins, and it said, time is cartilage. Because the longer you wait, the more damage you're doing. So this is the cartoon showing. So here's the joint. There's the joint space is almost gone, which means the cartilage is wearing away. And you can see you're having a fair amount of inflammation. But on the x-ray, you see nothing. The x-ray is perfectly normal. So when I was in training, we were taught that you don't do anything until you see some changes. And now we know if you wait for changes, it's too late. So this would be how it starts. Now it's getting a little bit more involved, and now you can see that this inflammation is actually eating into the joint. And where this was smooth before, you can see that a little erosion is taking place. A little bite has been taken out of here, corresponding to this little bite right there. And then as it gets worse and worse and worse, the pannus just keeps eroding into the joint. Now you can see it's on both sides. Here's the big bite out. Here's a bite out here. And now there is no joint space. So again, it's bone against bone. And this is looking at the swelling and the tobacco-stained fingers. And you can see there's swelling of the PIPs and then the MCPs. As it gets worse, you can see that now these are subluxed. So this hand is almost useless. And look at these big nodules here. And we had a patient who had these nodules on his fingertips. He was an elderly guy from Switzerland who was actually a watchmaker. And he couldn't do his work anymore, so we had to operate and take it. The orthopedic surgeons took them off so he could do his duty. And this is a really mutilated hand. Here's the X-ray. You can see it's totally subluxed. This hand just flails around. I mean, it's absolutely useless. In fact, it gets in the way. So the key features of rheumatoid arthritis are the symptoms usually last for 6 weeks before the patient can be diagnosed. So it can't be something that just happened 2 weeks ago. So that's why when you call me up on the phone and you said, you have to do something, I'm in terrible pain, I will say, how long have you had it? And you say, a week. And I'll say, no, I won't see you for 5 weeks. That's not true. But I mean, it has to be that it's 6 weeks duration. Because there are lots of types of arthritis that get better. For example, the most common we see here is parvovirus. It's like the dog parvovirus, but it has nothing to do with the dog virus. Children get it, and it's called the Fifth disease. It looks like the kids have been slapped when they're little. They have this red cheek. Anyway, adults get it from their children, and they have this arthritis, and it goes away in about a week. It's symmetrical. It involves many joints. It tends to involve, as I said, in the younger people, these joints, whereas in the elderly people, it involves larger joints. The course of it is the same in most people. There's 5 to 20% have this course here. Here's the severity of the arthritis, and it lasts only for a short period of time. I've never seen a patient like this. I guess they never come to a rheumatologist. By the time they get an appointment, they're cured. Then there's this one that's minimally progressive. That's the blue. So it stays around. The ones I always see are these, where it just keeps getting worse and worse and worse with time. So it has 3 different patterns, and if you're lucky, you're in this pattern. All right, the key points are, the sicker they are and the faster they got that way, the worse the future will be. So if their disease was very rapid and came on very, very quickly, chances are it's going to be that way. Early intervention can make a difference, and it's essential to establish a treatment plan early in the disease. So we always do things right away. 50% show joint space narrowing or erosions by the end of the first 2 years, and you can't do anything about it. That's over. You know, you've already got the damage, so we can't wait that long. By 10 years, 50% of young working patients are disabled. Death comes early from multiple causes, and compared to the general population, women die 10 years younger and men 4 years younger if they have rheumatoid arthritis. Now, one of the things that involves people that have to deal with surgery is subluxation of C1 on C2. And we've drawn this in here so you can see the difference. Here is the ring of the axis, C1, and here's the dens of C2, okay? So that it's sitting in here like this, and it's normally held in place by a synovial-line membrane. If you have synovitis, then this thing moves, and it can move up to 5 millimeters and be normal. But you can see this is normal. But when the patient flexes his head, this distance widens. And now this is loose. So if you were to stick the head back like this, and here, lie down, the patient could pit themselves. His bone could go into the spinal cord. And then you'd have a paraplegic patient or quadriplegic patient. One of the other things that can happen to the neck is that you say, well, where is it? Here's the because the bones get thin, right? So here's the axis right here. And the dens is, you can almost not see it. See this white space? So that's a very unstable neck. No, this isn't going to show up. You lose it, and why do you lose it? Because you can see that the dens now has gone into the foramen magnum as an inside the skull. So instead of besides having problems going flexion and extension, it can also go up. So again, anytime you see a patient with rheumatoid arthritis, you have to be very, very careful of the neck. Okay? And we recommend that patients have these lateral x-rays before anything is extensive done, and certainly before they would ever have anesthesia. Patients with rheumatoid arthritis also get these nodules. The nodules occur on extensive surfaces. I showed them to you on the fingertips. There it is on the elbow. Here are nodules in the chest, in the lungs. Here's a nodule in the eye. This was a terrible case. This patient had this nodule and was having lots of care. One day she was in the waiting room and all of a sudden she goes, oh! And her eyelid burst and she had it in her hand. It was really awful. All right. How do you control rheumatoid arthritis? Well, I showed you all those cells are growing. How do you control growth? You can have two approaches. You can alter the growth factors or inhibit cell division. And the greatest thing that's happened to patients with rheumatoid arthritis is we can now alter the growth by using cytokines. And the cytokines that are being used is one called TNF alpha, tissue necrosis factor alpha. And I've drawn a generic molecule here. So if this is a cell and it's making these pink cytokines, how could you stop them? Well, cytokines work. They're secreted by the cell. They go into the media, and they come back around and they act on a receptor. And they could act on their own receptor, or they could act on the receptor on another cell. So there has to be a receptor and a ligand for this thing to happen. So one of the ways could be you could say, well, let's make antibodies to this, and the antibodies will bind to the cytokines, and people have done that. Or you can say, let's make the receptor, and the people have soluble receptors. You give the receptor, and it soaks this up. This side we're not going to talk about. It's another approach. So the drugs, there are 3 drugs that are used to take care of patients with rheumatoid arthritis that involve antibodies to TNF alpha or TNF alpha inhibition. And they have made remarkable things. Patients who are in wheelchairs are up walking now. It's just amazing. We've never seen anything like this. But there's no free lunch. So what's the payment for that? The payment for that is that this is an immune problem. As you saw, it's T cells, B cells, and cytokines. And if you're going to stop the cytokines, then you're going to knock the hell out of the immune system, and that's what's happening. So what are we seeing? We're seeing people are getting increased amounts of TB. We're seeing that they have malignancies are developing. The malignancy problem may not be any more than we would see normally, but these are serious issues. And if the patients, when these drugs first came out, they were touted to be as pure as mother's milk. And so patients got an infection and they didn't, don't worry about it, just keep taking your medicine. And then there were a bunch of Dear Doctor's letters, and 30% of people died of septic shock. So if you get infected any way, you have to stop the drug. So this would clearly involve you. A patient with rheumatoid arthritis comes in and needs dental work, and you're worried about infection that might come from implants or something like that. And they're on these drugs. That could be extremely dangerous, and the patient should probably stop the drugs. So in elderly people, age does not appear to be a factor in the treatment, except for the fact that there are more side effects with non-steroidal inflammatory agents. That is, the patients are more likely to have perforations, ulcers, and bleeds. The CNS headaches and confusion that people have on high-dose non-steroidals is a problem, and they're more prone to renal disease. So the non-steroidals have more effects in the elderly, but they're the only ones. The disease-modifying drugs, which are methotrexate and then these TNF inhibitors I've talked to you about, have the same efficacy and same side effect profile as in middle-aged patients. So we don't need to worry about tapering or changing them. Now there are 2 types of arthritis that are really unique to elderly people. These are patients who are over 60 years of age. This is the definition. One is called a seronegative, which means it's rheumatoid arthritis factor negative. It looks like a very acute form of rheumatoid arthritis, in addition to synovitis. So the patients, like just the normal elderly people I said who would have rheumatoid arthritis, would have a very severe case. But instead of having red hot swollen joints, they have pitting edema of their hands. So their hands are all swollen, and if you put your finger on them, you can see your fingerprint. So it's of the hands and also the feet sometimes. Males equal females. More males than females. And the test for rheumatoid arthritis is negative, so it's a little bit different than rheumatoid arthritis. There are no erosions in this disease, and all the patients go into complete remission by about a year, from a year to a year and a half, 9 to 18 months. And they're very easily treated with low-dose prednisone, and they get better. This is a very strange disease we don't understand. It looks like rheumatoid arthritis. The patients feel terrible until you start them on a little bit of prednisone, maybe 10 milligrams, and they do really well. Now here's a caveat in elderly people. Peripheral edema and synovitis have been reported as initial manifestations of lymphoma, endometrial carcinoma, gastric carcinoma, and myelodysplastic syndrome. Now these aren't very many cases, but anytime you see this, you have to say, is this just a rheumatoid arthritis in the elderly, or is this really the first sign of cancer? And most people don't think about this. They go to their doctor and they say, look, and I have this arthritis in my hands, what are you going to do for me? So it's, again, All right, we're switching to another disease, and this is called calcium pyrophosphate deposition disease, and this is the one called Pseudo Gout. And you can see this is really only a disease of elderly people. This is the prevalence, this is age, and you can see it really, you can hardly even find it before the age of 50. Oh. How do you tell the patients of this? You can do an x-ray of the knee, and here you can see there's calcification of the cartilage in the knee. This should be clear like this, although there's a little bit of calcification here too. It should be black. And here you see there's cartilage. And this is the calcium pyrophosphate that's in the cartilage, and it breaks loose and causes an arthritis. And how do you tell? The joint is red hot and swollen. You put a needle in the joint, you drain the fluid out, and you look under a microscope and you see these crystals. This one is interesting because this patient actually has staph as well as crystal-induced arthritis. So I always tell the residents that the sun should never set on an untapped knee effusion. Okay, so there was a guy in town who we were waiting for our cars at a dinner one night for them to bring the cars around, and I was trying to make conversation with him. Hi, hello, who are you, and stuff, and he looked at me and says, "You don't know who I am. You don't even recognize me, do you?" Well, he said, "I was a medical student at school here." I said, "Oh, yeah." He said, "I went into rheumatology because of you." And I thought, oh, so my chest swells up, and I think, you know, what? I said, what was it about me that made you go into it? He said, "When I was a senior student, I was on the wards one time, and you answered the pager. And I said, 'Should I tap this guy's knee?' And you said to me, 'Do you have fingers?' And my sarcasm made him go into rheumatology. Would you think you'd say, 'Well, that jerk, I'm never going into that field. I want to become a heart surgeon.'" So the point of the little story is that you always need to, if you have a swollen joint, you need to send someone to get tapped. Okay, here's a condition that is extremely common, and we see this all the time, and this is a disease called PolyMyalgia rheumatica. The onset is after the age of 50, and usually after 60. Its highest incidence is individuals of Northern European extract. So we don't see as much of it here as we did do in other parts of the United States, but we still see a lot of it. Female to male ratio is almost, it doesn't make that much difference. The incidence approaches 1% in older populations, so it is extremely common, 1 out of 100. What are the clinical features? The clinical features are the patients complain of pelvic and shoulder girdle aching. So they ache around their shoulders and they ache around their hips. And if you look at their hands, there's nothing wrong. And if you ask them to do range of motion in their shoulders, they can do everything perfectly. It just aches. So it's not arthritis, it's just this aching. And they complain of terrible morning stiffness that they can't get up, and they're so stiff in the morning it may last 3 or 4 hours before they can get going. They have a rapid response to low doses of steroids, and that's the test. You give them 10 milligrams of prednisone, and 48 hours later they think you are God, because they're all better. They can have anemia, and then the hallmark is they have a very highly elevated SED rate. Their sedimentation rate may be as same as their age, it's so high. Or C-reactive protein. Does everybody know what a SED rate is? It's the rate, it's a non-specific measure of inflammation. So if you have a cold, you'll have a high SED rate. But it measures inflammation, it's sort of directly proportional. So you take red blood cells and you let them fall. Red blood cells normally have sialic acid residues on them, so they're negatively charged and they repel each other. But if there's a lot of inflammation going on, the liver makes all these inflammatory proteins, and the proteins bind to the negative charges, and then the proteins are plus and minus because of all the different amino acids, and they start hooking together, and they get a whole bunch of these red cells together. Now we have 100 red cells in a pack, and it falls faster. So the more inflammation you have, the faster the red cells fall, and the sedimentation rate increases. So a normal sedimentation rate would be that red cells would fall less than 15 millimeters in an hour. And patients with PolyMyalgia rheumatica usually are above 70, 80, 100, really very, very inflammatory. So that's a disease, and you give them a little prednisone and they get better. But the worrisome thing is it can be associated with another disease called giant cell arteritis. This is inflammation of arteries in the head, all the branches of the external internal carotid. This is, again, only seen in elderly people, never seen in anyone ever below the age of 50. 40 to 60% of patients with giant cell arteritis have PolyMyalgia rheumatica symptoms. In about half of these individuals, the PMR was the first symptom manifestation. So if patients come in complaining of this aching, the little dose of prednisone won't work, because besides having that, they also have this inflammatory process. And you have to treat them with long periods of time. So what is giant cell arteritis? We're almost done. We have like one or two more slides and then we'll be finished. Giant cell arteritis, patients complain of a headache. And they say it's like the worst headache they've ever had. It's a new headache. The pain tends to be localized over the temporal areas. The headaches may be mild or severe. Usually they're severe. And there's tender temporal or occipital arteries. So if you feel along temporal arteries, you can feel your own temporal artery. You can feel your pulse here. If you push really lightly. And that becomes very inflamed and it's very, very tender. Patients complain of jaw claudication. That means when they're chewing, it hurts. It doesn't mean when they're opening their mouth. It's not TMJ. It means that they start to eat and they're doing okay, and as they continue chewing, they get more and more pain in their jaw. And if they stop chewing, it gets better. And I'm going to explain how this happens in a minute. The visual loss is the most important problem, and this can be permanent. So the patients can get this and they become blind. And that's why you have to treat them immediately. You can't be fooling around saying, well, come back and see me next week. They'll come back, but they're pain in the dog, so you don't want that to happen. All right. So let's go over this again. Age greater than 50, a new headache, a temporal artery abnormality, an elevated sed rate, and then an abnormal biopsy. And the way you make the diagnosis is you have the patients go to a surgeon and they do a biopsy. They usually do it as an outpatient procedure because the temporal artery is right out here. And the reason they do the temporal artery is because it's easy to find. You could do one deep in the brain. That would be a little bit more trouble, whereas this you can make a skin incision and take it out. So it's the arteries, the deep arteries of the head and neck. So for example, we're doing out the internal carotid comes the ophthalmic artery. And if the ophthalmic artery gets inflammation, that is inflammation with lymphocytes and white blood cells, then it blocks the flow of blood, and that's blindness comes because you have no blood supply to the retina. If it involves branches of the occipital artery, it can give you a headache in the back of your head, and you say, I have a headache, and the doctor says, oh, it's tension headache, you know, it's nothing. Again, the eyes can be involved with amaurosis fugax, which means you're seeing spots before your eyes, you can see double vision, and if the lingual artery is involved, that's why you get the jaw claudication. So temporal arteritis, when you make the diagnosis, or you think about the diagnosis, you immediately start the patient on very high doses of prednisone, 60 milligrams. And then you have up to a week to get the biopsy done. The biopsy positive, then you continue, and sometimes patients stay on high doses of prednisone for a year. And as you all know, high doses of prednisone in elderly people cause lots of trouble. Patients can develop diabetes, they can get osteoporosis, they can get fractures of the spine due to high-dose steroids. So it's not easy. And there is really no other treatment. People have thought about using all sorts of other drugs, and none of them seem to work very well. So it's a very complicated problem when patients have this. All right, so we've talked about 5 diseases that affect elderly people. We've talked about osteoarthritis, which is the most common one. And again, remember, it occurs in almost everyone over the age of 70. The interesting thing about osteoarthritis is if you do x-rays of everybody coming out of HEB, people will have x-ray changes but won't have symptoms. And I think that's quite interesting. And we all know from people in this room, there are people who can have something and they die from it. You know, and you say, good God, it's just a cold. You know, and they're near death and complaining. And there are other people who, you know, just don't have it affect them as badly. And the same thing is true with arthritis. There are people who deal with it very, very well. And there are people who don't deal with it very well. There's an interesting study that was done at Northwestern University where they took this was done with rheumatoid arthritis, but they took patients and they had a hidden camera in the room, and these women had terrible arthritis. and they were bitching and moaning, and life was really awful. And they put them in a 12-week aerobic conditioning class. And for some of them, getting up from a sitting position would raise them to their target heart rate. I mean, they didn't have to do much. But they did this in water. And again, at the end of the time, they're back in the room with the hidden camera, and their arthritis isn't any better. Their arthritis is just the same, but their attitude is different. And now they're planning vacations, they're doing shopping, they're doing wonderful things. And the sad thing about it was, then the study ended, and all the patients agreed that they benefited from exercise, and none of them kept it up. So it's like, example, in front of the room. So I think that there are many, many ways besides using medicines that people can use to approach these types of arthritis, particularly osteoarthritis. I had a patient who had bad osteoarthritis of his knee, and he was the head of PE at Berkeley. What the hell am I doing? At Berkeley. And his brother played for the Oakland Raiders. And he came to me, and his quadriceps were bigger than my whole body. And I called this sports guy up, a sports orthopedic surgeon, and I said, what should I do with this guy with this patellofemoral? Anyway, he said he should rebuild his quads. I said, this guy's quads are so big I could hang off of him and he could hold me. He said, you know, you can't be too thin, too rich, or have too strong quads. So I reluctantly put him in this class, and he strengthened his quads, and it went away. And the guy was so grateful to me. And I kept saying, you know, I'm free on Sundays. I don't have anything on Sunday afternoons. And he never gave me tickets. I'm so angry. So I transferred him to the residence pool, and he had to have the residence meet his doctor. I'll show him. So exercise is really important. And if you can get people to do exercise, when the Arthritis Foundation was before it went under, they had a program called PACE, People with Arthritis Can Exercise, and it was water exercises, and it was absolutely wonderful. And it was being done in all the pools. You have to have a warm pool, but I mean, it was just amazing what people could do in water. And it's a shame we don't have that anymore.
What kind of exercise is this?
These were just conditioning exercises, just to get you, and just movement so that you kept range of motion going.
That's why the jacuzzi works.
No, the jacuzzi works, but only works for 15 minutes. And once you get out, it all comes back again. Heat and cold works temporarily. This really worked for a long period of time, and nobody understands why. Some people think, well, because you strengthen your muscles and you improve things. Others say it's because of the endorphin release. So the people would go 3 times a week, and they would have real exercises, and they would get their heart rate up to their training heart rate. But you did it in the pool, so the buoyancy helped your joints. Whereas you couldn't do it, these patients with arthritis can't do aerobics and things because their knees are too bad.
Yeah, I'm not sure I was going to get a bathtub roll pool, but if I can't do the exercises, then that's wasting money, I guess.
Well, it depends what kind of arthritis you have. Some of the ones that are more soft tissue, that aren't really arthritis, can be helped by those baths. Like fibromyalgia is really helped by that.
I have that really.
Yeah, that heat really is the only thing, that's really a good thing.
That's probably right.
Also, massage therapy is good. If you can find a massage therapist, that's really good.
Yeah, me.
So patients should all be educated to understand what they have. They should be sent to physical therapists who can help them, and then they should be sent to occupational therapists who put them through, and I don't know if you've been in occupational therapy groups, but they have little kitchens and things. And they put people in there and they say, now pretend like you're going to make breakfast. And they watch how they use their hands and how they conserve motion, and they teach them ways of doing things that they don't put the strain on their joints and things. And that's very, very helpful. Rheumatoid arthritis is the worst one we've talked about from an arthritis point of view, because we really don't have anything. Hopefully these new TNF-alpha inhibitors will be able to turn off the disease, but up to this point we've never had any drugs that did anything. And we used to say you left your fellowship program and you were all excited about how you're going to stamp out disease, and after 10 years, well, I didn't help all the people, but I certainly helped a lot of them. And after 20 years, you said, well, I don't think I did anything, but I'm really a good friend of my patients. I think we don't have to say that anymore. I think we can say in rheumatology now we do have medicines that are going to make a difference. And then we talked about pseudo-gout, and pseudo-gout is treated just with non-steroidals. So if the patient has an acute attack, they keep Motrin, Indocin, Felding, whichever drug you like, they all work on hand, and they just start taking it. And it gets better. The trouble is it keeps coming back. And then PolyMyalgia, Rheumatica, and temporal arteritis are more serious, especially temporal arteritis. And so if you happen to have patients tell you about how they have this terrible headache, how they have jaw claudication, you really need to make sure they get to see somebody, and not put it off, because it would doing them a great favor if you could stop them from being blind. All right, any questions?
Yeah, recently I've heard that fibromyalgia was an autoimmune disease like rheumatoid arthritis. I hadn't heard that before.
No, it's not
How-
true. It's not true. Fibromyalgia is probably a neuropsychiatric disease in the sense that all of the defects that have been found in fibromyalgia are neurologic. So if you put a person in a dynamic MRI machine and you give them a pain stimulus, they light up different parts of their brain than do people without fibromyalgia. Secondly, the neurotransmitters like serotonin and substance P are all screwed up when you do spinal taps.
Yeah.
So it's like something's activated and doesn't shut down. So the simplest stimulus is very, very painful. So I really think it's going to be a neurologic disorder.
Well, what
Not
What is
autoimmune.
becoming recent, what has come up recently and what has been started out for the past year is what hormone. I had they found out virtually had no hormone, 0.9. So that has improved about 90% of my symptoms, about 80%.
Well, there are some of us who don't believe in fibromyalgia. I mean,
Yes.
we think it's all a real, another disease, and it's just the body's manifestation of something else that doesn't exist by itself, like you know, was secondary to something. Like, for example, fibromyalgia is certainly seen in patients with thyroid disease, hypothyroidism, and if you replace the thyroid, there's some studies done with fibromyalgia recruits, and they did it in students as well, and if you put them in a sleep lab and you, every time they go into stage 4 non-REM sleep, you wake them up, in 48 hours they have the trigger points that ache, just like everything else, and when their sleep's restored, it gets better.
Oh yeah, my sleep, I can sleep, I can sleep through the night now. I can never sleep. I haven't slept in years.
Yeah, no, so that's
You know, a year, an hour or two at a time is not, now I can, so I guess it does help with,
but I don't think it's autoimmune. I think it's due to many things.
it's just a symptom of something.
Yeah, but I'm wrong probably. Okay. I've never been right yet, and I'm ready to stop doing this, so maybe one year I'll get it right. Any other questions? Okay, so now I can have a short nap.